And then about 6 months after this, we decided to climb this tree house that had metal stairs. She fell and she hit her head, bleeding, carrying her to the emergency room, gets a CAT scan. Fortunately, she doesn't have a cranial fracture or a hemorrhage, but she did have an incidental Chiari-1 malformation without hydrocephalus or without a syrinx. And this was just, it hit home to me that, wow, because I've seen so many patients that have been affected by this, but yet I've also seen many that have not been affected by this. And my story is the 85-year-old lady when I was at Georgetown doing residency who had her first stroke on MRI, who had a pretty decent-sized Chiari and seemed to make it through her life without any problems. So it is a very, very diverse set of symptomatology associated with this. And she's a teenager now. I don't think I can blame the Chiari on her teenager stuff, like not wanting to talk to her dad and texting. But I don't know what the future holds for her, right? So there's a lot of unknown. So today I'm going to give you a little talk about the symptoms associated with this. I don't have to talk to this audience about this largely because many of you are dealing with this yourselves. We'll talk a little bit about the proposed mechanisms of the pain, not at a geeky scientific level. I mean, I might kick it up a notch a little bit, but I want everybody to really understand the complexities. We'll talk about non-opioid management, which I think is critically important. And then I'll just give you my perspective, not just with Chiari malformations, but just my journey with cancer and with patients that are dealing with pain in my perspectives. So in terms of symptoms associated with adult Chiari malformations, we have occipital headaches, neck, shoulder, back pain, cranial neuropathies, balance issues, cognitive dysfunctions. And then in those patients that have syrinx formations, they can have paresthesias, weakness, incontinence. I've seen plenty of that on the adult side. On the pediatric side, there's a lot of overlap with symptoms. So this was a study that was published in 2009, so not too far ago, looking at a bunch of patients from the Kaiser healthcare system, over 5,000 patients, looking at imaging, looking at symptomatology, and 1% of those patients had an associated Chiari. And the presenting features were mostly headache and neck pain, but there were some other rarity of symptoms as well too. So there is an overlap between these two populations. So what are the theories of symptomatic Chiari-associated pain? And there's really about 4 or 5 major ones. One of them is a small posterior fossa. Just that foramen magnum, that space is just embryologically small, and that is somehow related to it. The other one is the cord tethering phenomenon, that patients have fatty phylums, the cord gets stuck, it's kind of yanking down, and because of that, there's tension on the cerebellum through the foramen magnum. There have been some cadaver studies that have really leaned against that, but still that's one potential hypothesis. And the other two have to do with joint instability, whether it's the atlantoaxial joint or the atlanto-occipital joint. How is this all related to changes in cerebral spinal flow? And then there's, of course, the physical trauma as well as stress too. So it's very complicated. Now, what are some of the proposed theories of Chiari-associated pain? Well, a lot of them have to do with flow of the cerebral spinal fluid around the space, as well as the flexibility of the dura to expand and contract. Every time our heart beats, you've got a change in your arterial pressure, your venous pressure, your CSF flow. And I think that we don't have a great animal model for this disorder. So largely a lot of this is hypothetical, but when you look at it, it all makes sense. And these are more of the biomechanical proposed mechanisms of pain. This is where it gets really complicated. So this is really what it's all about, in my opinion. It's about connectivity. Billions of neurons connected from the brainstem up into the brain with these critical structures in the thalamus, in the amygdala, in the brainstem, in the cerebellum. These connectivities are critically important to how our body understands pain and our perception of pain. And there's a lot of crosstalk not only within Chiari-associated pain, but other disorders too, such as headache, migraine. So I think we have a lot to learn from other neurologic disorders associated with pain, because there could be some really fundamental areas here that overlap. Now, what are some of the non-opioid management options of Chiari-associated pain? And I'm mentioning non-opioid because I think across many diseases, we've done a disservice, both us, the pharmaceutical company, Congress, healthcare regulations. We've really gotten ourselves in this deep hole with regards to opioids. And opioids are really just a Band-Aid. And the symptoms, the withdrawal symptoms, the dependency, are things that we've really got to tackle as a society. So I want to focus on what are the non-opioid management. And so some of those involve anti-seizure therapies, corticosteroids, non-steroidal anti-inflammatory drugs, NMDA receptor antagonists, local anesthetics, nerve blocks, scalp blocks, neuromuscular blocks. I'm sure many people in the audience have probably experienced all of these already, or some of them, so I'm preaching to the choir. But this is really what Western medicine has to offer for pain. And when we look at some of the pharmacological mechanisms here, we're really getting down to that cellular level, at the nerve root level, at the central brain level in terms of how our body distinguishes painful from non-painful stimuli. And a lot of our medications act on that cellular level to block a variety of channels like sodium channels, calcium channels. They modulate GABA or NMDA, all of these neurotransmitters that ultimately leads back to feedback signals within the central nervous system. Now, one group looked at this, and they looked at how do we really identify pain specific for Chiari? What has been published in the literature? So this was just a recent paper that was published this year, looking at a literature review, looking for Chiari-specific evidence. And surprisingly, there's only a relatively small number of studies that really met the rigor, the scientific rigor, for us to be able to discern what some of these mechanisms are and what some of the treatment options are. The majority of them are pharmacologic. There's a couple surgery or surgery followed by pharmacologic. And really, the data is a little bit all over the board, but most of them support some of these treatments. Now, when we're looking at some of the major classes of therapies, and this is from a dumb neurologist who I've just got the power of the pen or I guess the keyboard now to write these prescriptions, what are some of the drugs that we're actually looking at? Well, we've got our old-fashioned anticonvulsants, our anti-seizure therapies. Most of them are modifiers of sodium channels, but some of them are modifiers of GABA as well too. And a lot of these medications have side effects. They've got side effects on the liver. They've got rashes. I call Topamax Dopamax because it can really slow you down and you can have word-finding difficulties. Same thing with some of the antidepressants. When they're used at higher doses, you can have cardiac arrhythmias, dry mouth, dry eyes, all sorts of complications. Even the injectables, the analgesics, the local anesthetics, you can have nausea, vomiting, vertigo. The diuretics, it's just a medicine that allows you to urinate more fluid to control pressure. But even some of those have horrible nausea, vomiting, fatigue, numbness and tingling of the hands and feet, electrolyte disturbances. When you're talking about Botox, you can have paralysis, systemic botulinum toxicity leading to respiratory failure. And then in terms of the cannabinoids, we're still learning. To be honest, that's probably one of the more safer groups in the bunch because it's natural, but even then, there are some significant toxicities as well too. So I think it's really important that we differentiate the cause of the pain Is it related to the Chiari itself, or are there other alternative explanations? And I say that just because of how common this finding is and how you have to treat every single patient differently. And you really, as a physician, to do it right, sometimes we are just focused on that finding, that radiology report, and we just have blinders. We're just tunnel vision. And I think a lot of mistakes have been made because we don't look at the big picture to look at the patient to see what are the rest of the symptoms and what are the circumstances. And that can be critically important in order for us to help guide our therapies. So what is the role of acupuncture for Chiari-associated pain? And I have to tell you, as an Eastern-trained doctor, Western trained, sorry, that was a slip, but my wife will appreciate that since she's an acupuncturist. And we have a great school here in San Diego. I've developed a real appreciation for acupuncture, and you can only imagine some of the, not arguments, but discussions that we've had about acupuncture and functional medicine. And really what she has done is she's really taken me out of that box of Western thinking, right? Chinese medicine has been around for 3,000 years. I think there's something to it. Just because we can't explain the mechanism of why it works, it doesn't mean that it doesn't work. And as she reminds me, when you're doing these therapies, it's Chinese medicine, it's not Chinese magic, right? This is not a one-time treatment. You really need to continue with multiple sessions for it to be efficacious. Now, what about the role of cannabinoids for Chiari-associated pain? And this is an area that's under intense investigation. And I have to admit, I was probably one of the biggest skeptics early on in my career. I think the gray hair has given me a little wisdom by hearing patient stories. But how is it that a patient's family, a child with intractable epilepsy, ended up being severely affected in a positive way by the use of THC, and now that medication is FDA approved. And that came from a single patient, a family, an advocacy group. So this is one of the biggest points here, is that together, when you have a common cause, we find solutions together. And so I think that the stigmata of the cannabinoids is long gone now. Every major medical center has Eastern medicine, has alternative therapies, or they should. If they don't, you should really find one that does, because these are naturally occurring compounds that cross the blood-brain barrier, and they actually regulate some of those nerves and some of those pathways that I was showing you before. So critically important. What about the role of yoga? I was going to say Yoda, sorry, that's my Star Wars in me. Yoga and meditation for pain. And I think, again, this is critically important too. These therapies have been around for hundreds and hundreds and hundreds of years, and there is something to be said about our natural endorphins that can be released through exercise and meditation that, again, we don't understand. But as a Western-trained physician, do you really have to get that P of less than 0.05 in a clinical trial to prove that something works? I don't think so. Another technology that I'm excited about is transcranial magnetic stimulation. This is a whole new field where we're talking about an area called neuromodulation. So our brains are batteries, essentially. Our nerves are constantly firing. But when you apply an external magnetic field to these neurons, you can actually affect the frequency of firing. And this technology has been extraordinarily important for depression. It's FDA approved for depression. But I think there's something else to this technology. This is not an implanted device. This is an external device. There's a lot of promise. And it's been shown even at the cellular level that you can have modifications of what we call thalamocortical signaling, which is where the majority of these pain pathways are found. And this is really largely done in mice work. But with imaging techniques, we're actually able to bring this to the next level. And I'm hopeful for this technology. It's non-invasive. It's not completely covered for pain yet, but I think there's much more study, and I don't know if anybody in the room has had TMS, but that's something maybe to put on your list. Now, differentiating cause and effect can be very, very difficult in a common disorder. How do you know whether a patient is symptomatic, asymptomatic, just based on imaging alone? And this is really important because the placebo effect is about 33% in everything that we do. Whether there's a new drug coming out for pain, for seizures, for headaches, 33% of people that take a sugar pill will have an effect. And why is that? And on the contrary, the nocebo effect, right? There are patients that take the placebo that have horrible side effects, right? Vomiting, dizziness from a sugar pill. So that to me says that there's a lot here that's unknown, and particularly the mind-body connection. And I think that's where a lot of alternative therapies come into play, and we just haven't figured that out yet. So when you look at natural history studies looking at pain severity, over time we know that you start out here with horrible pain, and if you follow patients across the course of months to years, even with no treatment, the general trend is to get a little bit better over time. Now, it's possible that that placebo effect, you get even better over time, and then the hope is that with the drug, that's going to be superior to placebo. But I would argue what's going on in here, and how can we really utilize this mind-body connection to get us perhaps down to here without some of the side effects. And so looking at this combined model of the placebo response, it's really a combination of input, the source of learning, mediation, another form of learning, non-conscious versus conscious learning, and then an output system. The output is the physiological placebo effect and the subject placebo effect. And how do we translate this to a biological response, one that we can measure? And I think that it's important to look at the contextual factors as triggers of placebo and the nocebo effects, right? In terms of what are the clinical characteristics, the headaches, what is the relationship with the patient, the expectations, what are the patient characteristics? And then looking at that nocebo-placebo effect, what are the endogenous effects of that within this complex circuitry within the brain that ultimately leads to an effective therapeutic outcome? And so you're not going to get away with this geeky slide, because we're going to come back to this again, because this is really the importance of understanding this complex nature of connectivity. How do we get from emotion to cognition to pain? What is the feedback loop here? And how does that translate to a variety of chemicals, neurotransmitters in the brain? Some of them we can target, some of them we cannot target. Remember, one of the challenges in neurologic diseases is getting drugs across the blood-brain barrier. It's our filter system that differentiates and blocks certain drugs based on the size of the molecule and the charge of the molecule. And so that's, at many times, a limiting factor in terms of our ability to target these areas. And number two, target them specifically. If you give a drug, you want it to go on target, but the off-target effects sometimes can be really detrimental to the patient and make things worse. So in mouse models, you can show by doing experiments that you can modulate pain perception based on distraction. And that's been critically important. It can be associated with good mood and bad mood. And how do you know if a mouse is in a good mood or a bad mood? Well, they like to run around, they like to eat, they like to look at things. That's what they do. And I think when they're ticked off, they don't do that, right? So, but I will say that translating mice to humans is a gross oversimplification. And we've seen this in cancer, where we can cure cancer in rats and mice, but we can't in humans. So just know that that's not a one-to-one, that we've got to think well beyond that. But it is a good start. And we know that there are changes of the brain in patients with complex pain. We know that there are upregulation of certain receptors, downregulation of certain receptors, and these really impact our ability to respond to opioids, to respond to some of these other therapies that are happening. So we know that pain changes biology. We know that at the cellular level. We know that there's neuronal wiring. We know that from deprivation experiments in mice. And we know that with some of the patients that I see that unfortunately are born to drug-addicted mothers that are neglected their whole lives, we know that that affects brain development. So these are critical pathways that need to be explored. Now, the last part, I want to talk about the value of clinical trials. I think this is critically important that we think about this in an outside-the-box way, of course, but in a very methodical and responsible way, because as you know, there's a lot of snake oil out there, a lot of people that are doing things that for $299, we'll send you something in the mail. And there's some truth to that. I think some of those therapies work, but I think we owe it as a community, especially within this community. We have a responsibility to make sure that we're rigorous in our approach to this. Now, clinical trials are near and dear to me in the cancer world. Back about 40 years ago, leukemia was a death sentence in children. And because of collaboration in clinical trials so that we're not repeating the same mistakes that we've made, now leukemia is more than 90% curable in kids. And so that really is the model for clinical trials and the benefit of it, where we go from the patient to the microscope to the lab to be able to study these things, look at some of them mechanistically, and then bring them back to the patient so that we can make our patients better. Now, I was a little disappointed when I went to clinicaltrials.gov. I don't know if any of you have ever been to that site before, but this is really our large clinical trials site. This is where everything is available for a variety of diseases. And this is all I've got so far in terms of recruiting. Turkey, the investigation of the effects of exercise on patients with Chiari malformation. I think that we've got a ways to go. I think given how common this disorder is, how many people it's affecting, there needs to be many more options for all of you and other patients. And how do we get there? I think it's really the power of advocacy. I think as a group coming together, I would give yourselves a lot of credit in terms of what you've done and what you can do as patients, because patients have a voice. And we're seeing that more and more with a variety of disorders. This is how advocacy groups gets in front of you-know-who, Congress, right? Doesn't matter if you're Republican, Democrat, Independent, atheist, Catholic, it doesn't matter. As a group, you get together with key leaders, and that's really where the direction of the research comes, the NIH dollars, the clinical trials. But you know what? If you're not happy with government and you raise enough money, you don't need them. You can have your own clinical trials fund where you fund your own trials that are important to you. And I think that's critically important, because to get back to the oncology model, we used to start treating cancer as all one thing, or what something looks under the microscope, we just treat it how it looks like. But as we've unraveled some of the genetic underpinnings of cancer, we've realized, wow, this is not one disease anymore. This is an N=1 disease. And I think Chiari is really no different, because it's well beyond what we're seeing on imaging or flow studies or the presence or absence of a syrinx. Well beyond that. We need to study biomarkers, natural history, things of that nature, so that we can treat patients individually. And then when we have a good story, a super responder, we need to figure out why. Why did it work for Jim, but it didn't work for Betty, right? And I think only as we start to really expand the phenotype more and really get into more personalized therapies, will we really be able to solve this very, very complex problem. So I want to thank you all for your attention, and I appreciate you all very much. This is a very, very complicated disorder. I know I probably oversimplified everything, and you probably know a whole lot more about this than I do, but happy to answer any questions, and thanks for inviting me today.